Afternoon, everyone. I am Denise Dador, and I am the medical reporter at ABC7 Los Angeles. And we're here for Community Connections. And we have a partnership, ABC7, with the American Lung Association and City of Hope. And we're here to present this forum to help educate people and bring awareness to lung cancer as it relates to every one of us living here in the Southland, because we all have issues with air here. And also for young people, because this is something that's happening in the next generations of younger adults, early onset. And so we really feel it's important that we bring attention to this. And we're so thankful that all of you are here to be part of this with us. Now, the American Lung Association was founded 120 years ago. It's the leading organization working to save lives by improving lung health and preventing lung disease through research, education, and advocacy. Recently, the mission of clean air is more important than ever in the wake of the devastating wildfires. And, I'm sure you were watching. ABC7 was proud to be there we were there, that's our job, to make sure everybody is safe and spread information. And we're also proud to partner with the American Lung Association and our experts today, City of Hope. We're going to bring you education, resources, and above all, hope to our community as we rebuild. Today, we will talk about lung cancer. It's a rare opportunity for us to hear directly from esteemed doctors on the forefront of lung cancer patient care and treatment. And we'll have a conversation for the next 45 minutes and invite all of you to put your questions in the Q&A. And the last 15 minutes will be reserved for answering your questions, and anything we don't get to, we will follow up and you'll get the answers via email. So about our panelists who are taking time now to be with us today, Dr. Ravi Salgia. He's the Arthur and Rosalie Kaplan Chair in Medical Oncology at City of Hope, where he leads over 100 faculty members. Previously, he held leadership roles at the University of Chicago Comprehensive Cancer Center and was a faculty member at Dana-Farber Cancer Institute and Harvard Medical School. He earned his MD and PhD from Loyola University in Chicago and completed training at Johns Hopkins Hospital and Dana-Farber. Board certified in medical oncology, and he has received numerous NIH grants, patents, and research awards. Dr. Salgia has authored over 550 publications, co-edited journals, and frequently presents at international conferences. He serves on multiple advisory boards and is recognized among the best doctors and top doctors. So we're so privileged to have him today. And also with us, Dr. Abigail Fong. She's an assistant clinical professor of thoracic surgery at City of Hope Cancer Center Duarte and South Pasadena Clinic. Dr. Fong has an MBA. She brings her expertise in innovative surgical techniques to patients undergoing treatment for diseases including lung and esophageal cancer and neuroendocrine and sarcoma tumors. After earning her medical degree at the University of Chicago Pritzker School of Medicine, Dr. Fong completed a residency in general surgery at Cedars-Sinai Medical Center in Los Angeles, followed by a fellowship in cardiothoracic surgery at the University of Pittsburgh Medical Center. She also completed the American Association for Thoracic Surgery's Surgical Robotics Fellowship and holds an MBA in Healthcare Administration from the University of Colorado. So both of our panelists, very well-rounded with a super laser focus on lung cancer. So we're going to begin right now with Dr. Salgia. First question that we have for you: what exactly is small cell lung cancer, and how does it compare to other types?
Thank you, Denise. Nice to see you. Nice to see everyone as well. I'm proud to be here with Dr. Fong. And lung cancer is various different types. Majority of lung cancer is non-small cell lung cancer, and that can be divided into adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and other types. And the other type is small cell lung cancer. Small cell lung cancer 25 to 30 years ago was about 25% of the population in North America. And now small cell lung cancer is about 15% or less in North America. Majority of small cell lung cancer arises because of smoking, but we're seeing small cell lung cancer in other scenarios, such as previous radiation therapy, even potentially radon exposure, but also in our patients who have, for example, EGFR mutations who get certain types of therapies, they can transform into small cell lung cancer, not very frequently, but it can happen. And what small cell lung cancer is, it's a small cell that's under the microscope. It's about twice the size of a white blood cell, and it's very compact nucleus with a very small cytoplasm, but it grows incredibly rapidly, and we have to be aware that it can metastasize much more quicker than non-small cell lung cancer.
All right. Well, Dr. Fong, just a follow up to that. You said it's mostly because of smoking, but also radon exposure. Can it just come up? Is this one of the cancers that comes up in a lot of people without smoking?
So, almost all lung cancers are much more common in people that smoke, and small cell lung cancer, that is one of the biggest risk factors. It's much, much less common in people that don't smoke.
Ah, okay. So if you could round this out and let us know, Dr. Fong, what is non-small cell lung cancer?
Sure. So non-small cell lung cancer, and thank you for everyone for having me here today. I'm excited to speak with you all. Non-small cell lung cancer is sort of all the other primary lung cancers, cancers that come from the lung itself and not from other tissues that metastasize to the lung. So like Dr. Salgia was saying, it's about 85% of lung cancers are non-small cell lung cancer. And the most common is adenocarcinoma, followed by squamous cell carcinoma. They come from different cell types, but are the most common kinds of lung cancer. And then there's a small percentage that are other things, neuroendocrine tumors, large cell carcinomas, things like that.
Okay. Dr. Salgia, let's talk about risk factors. What increases a person's risk of developing lung cancer?
So we talked a little bit about smoking in the first question, but there are other risk factors that we have to be aware of. We know that, for example, radon is a potential risk factor. We also know sometimes genetics can be a risk factor. And most recently, it's been identified, there was a paper published in Lancet Respirology where they identified pollution can be a risk factor for leading to lung cancer. And these are important things, especially in Southern California.
Yeah, everyone's pretty scared about that because a lot of people feel like, I didn't smoke and now I have lung cancer. And how did that happen? And it seems like air pollution seems to be one of the newer things that keep popping up.
Oh, absolutely. And this is why we have to keep in mind, we know that air pollution is a huge problem, not just in Southern California, but places like China or India and other places. And we have to really pay a lot of attention to this. And as we have to be cognizant environmentally, as the American Lung Association has done for a long time, we have to make sure we protect ourselves from these pollutants.
Yes. Okay. And Dr. Fong, when people get lung cancer, when they finally get diagnosed, they probably have been ignoring the symptoms, right? You always hear about that. So what are the most common symptoms of lung cancer and when should someone see a doctor?
Sure. Um, Unfortunately, early stage lung cancer frequently doesn't have very distinct symptoms. Um, Frequently, what we hear from patients is that they have cough or worsening shortness of breath. And in general, if that is a persistent thing that a patient is having, it's probably worth seeing a doctor, if nothing else, so that they could treat whatever is going on, whether it's lung cancer, or whether it's just an infection or asthma or something else. Then as more worrisome things that we see in lung cancer patients are if they start having, weight loss or sort of chest, shoulder, or rib pain. And you can see that as things become more invasive. And, there's just sort of a general malaise that can go along with all of this as well. Unfortunately, a lot of the symptoms are kind of non-specific, but also in general, if you have start feeling just kind of generally bad, I think it's always a good idea to go see your doctor and see if you can figure out what's going on.
Is it usual for when a patient presents to you that they've been suffering from this for like many months, maybe even years?
It's not uncommon, unfortunately, that the patients have had sort of ongoing symptoms for a while. Unfortunately, some of those earlier symptoms, cough, shortness of breath, can also just be seen in people that smoke a lot. So sometimes patients write it off as just symptoms of their smoking.
Ah, okay, so Dr. Salgia, that brings us to our next question. Like, how do you check for lung cancer? What tests are used?
Yeah, so early stage lung cancer is difficult to identify, but we have guidelines that say, we should do CT screening, and that's really our holy grail. And we have certain parameters that we utilize for CT screening, but they will change over time as well. You know, initially the CT screenings were defined because of smoking or cessation of smoking. But at the same time, we know that many patients have never smoked or never even had secondhand smoking that you might want to consider for screening. And we have clinical trials with respect to that here at City of Hope as well. So you could do CT screening, but then you have to diagnose what you see on the CT. So if you see a pulmonary nodule, that's where Dr. Fong and our colleagues come in to be able to biopsy that or take that out to see if indeed that can be cancerous. And we're also developing blood tests here at City of Hope, but many institutions and many companies are doing that worldwide as well. So can you do a blood test like you can, for example, like a PSA for prostate cancer or CA-125 for ovarian cancer? Can you have a blood test for lung cancer so you can screen for early disease? And those are all the ways that you can think about lung cancer screening and diagnosis.
That's very exciting. I mean, from what I understand, that's the way that cancer screening may be conducted in the future through blood tests.
Oh, absolutely. You know, CT screening is our first foray into this, but then these blood tests are the second foray. But are there potentially other radiological maneuvers that one can use, even, for example, like a PET scan? But I caution us about a PET scan because that's a lot of radioactivity. So you have to have poor screening and very good sensitivity and specificity without toxicity.
Ah, and as far as CT scans, like when should a person go? Like I think there is a recommendation that if you're a longtime smoker, that you should get checked. I mean, is there an age or years of smoking?
Yep, there are very good definitions in terms of years of smoking, when you stop smoking, the age that you have. All of those are taken into account for CT screening. What I also say is that if you can get involved in a clinical trial, that's a good thing as well for screening, because we also believe, especially in Southern California and in our Asian population, that you can develop lung cancer, especially in females, without necessarily having that age or smoking history.
Yeah, maybe Dr. Fong, you could talk a little bit about that. And we're going to talk about treatment options, but are young women, and especially Asian women, more likely or are starting to get more lung cancer? Oh, I think you're on mute, Dr. Fong.
How about now? Can you
Yeah,
hear
there
me
you
now?
go.
There we go. Unfortunately, we are seeing an increase in this population, frequently with genetic mutations rather than smoking as their leading cause of likely lung cancer. And that's why it's so wonderful that I have amazing colleagues like Dr. Salgia who are working so hard to help figure out best ways to treat these patients.
All right, that's the genetic factors. I mean,
Mhm.
I know there's nothing you can do about, sometimes they say, is it just bad luck? Is it just genetics? But I know there are modifiable risk factors as well. And maybe there are things you can do to help, I don't know, prevent the genetics from actually turning on. Is there?
I think you can definitely try and limit, known exposures if you have, try and have good air quality, try and avoid, a lot of smoke. If you are smoking, stop smoking, try and prevent radon exposure or other pollutants. Um, uh, anything that's going to be irritating to your lungs is probably not going to be the most healthful thing to your lungs. And then don't ignore any symptoms. You know, if you have persistent symptoms that are not going away, it's definitely worth investigating to see if something's going on.
Yeah, I don't think we can remind people about that enough. So let's talk about treatment options. Once you're diagnosed with lung cancer, Dr. Selgio, why don't you start? What are some of the treatments available and how do they work?
So I'd love to hear Dr. Fong for early stage disease, and I'm going to talk a little bit about late stage, if that's okay. Um, in medical oncology, we treat all different types of stages for lung cancer, but we really started off with late stage disease for lung cancer. And it truly depends on if it's small cell versus non-small cell lung cancer. That's where I'd like to start. So for small cell lung cancer, early stage disease, we treat majority of times with chemotherapy, radiation therapy, followed by immunotherapy, and potentially even brain radiation, what's called prophylactic cranial irradiation. Then that's one formula that we utilize in our clinical practice. But the other one is for non-small cell lung cancer. Now that becomes quite tricky. The way we think about this is a squamous histology versus a non-squamous histology. So as Dr. Fong talked about the non-squamous histology, the majority is adenocarcinoma. And then of course, you can have sometimes large cell carcinoma, not as common as compared to adenocarcinoma. So the non-squamous histology that is adenocarcinoma, there are many mutations that can occur. So, lung cancer is no longer lung cancer for me. It's a cancer that arises in the lung that has certain characteristics. It has the characteristics under the microscope, such as the adenocarcinoma versus squamous versus small cell. It has characteristics like genetic alterations, such as EGFR mutation or ALK fusions or ROS1 fusions, or other genetic abnormalities like MET exon 14 or MET amplification. Once we get to know that, we also want to figure out the immune signatures, such as the PD-L1. Then if someone has a genetic alteration and there's a drug available for that, then these are majority of time what are called small molecule inhibitors or targeted therapeutics. So for example, if somebody has EGFR, exon 19 deletion or exon 21 abnormality, such as L858R, then we consider therapeutics like Tagrisso or osimertinib, but we can also consider other therapeutics like amivantamab and lazertinib. But then ALK fusions, such as if you have an EML4 ALK, then that's a completely different therapy, such as lorlatinib or alectinib or ensartinib. Then if you have, for example, ROS1, then that's a different therapy, entrectinib, repotrectinib. I can go on for a long time because these genes and genetic signatures are clearly very important for us. Then immunotherapy becomes important too. Do you do single immunotherapy? Do you do double immunotherapy? And the treatment for us, and what I highly recommend for all of us in this audience, is to be able to consider, are you qualified for clinical trials? Those are important to lead us at the forefront of medicine. And those are some of the easier ways to think about lung cancer. I think of it much more like a mind mapping. So you can have adeno versus squamous cell carcinoma, you can have small cell versus adenocarcinoma, and you can have EGFR versus non-EGFR mutation or ALK versus non-EGFR, and so forth, and then decide on the therapy, and then truly decide, well, what toxicities you'll have. So those are all considerations we take into account. And you could imagine these are not easy decisions to make, right? You have to first and foremost get the right diagnosis, then you have to do the right staging, then you have to be able to come up with the appropriate therapy, and then follow for toxicity as well.
Wow, you really have all those genotypes down. But I think if we're listening, for those of us who don't understand all the numbers and identification, is that what you're telling us is that it's very customized, it's personalized medicine. And so if people come to you or any doctor who's versed in this, they know that they're going to get targeted therapy exactly for their disease.
Yeah, so I like your terminology, personalized medicine, and that's what we use. A lot of times people hear about precision medicine. Precision medicine is about the omics. It's looking at the genomics and the proteomics and the immunomics. And at the same time, that's not good enough. You have to take the person into account. What is their age? What is their performance status? Will they be able to tolerate one therapy versus another? So you truly have to personalize each individual. As you start the therapy, as you monitor the therapy, if toxicities develop, how do you change the therapy? Or if there's progression, how do you personalize that progression? All of that has to be taken into account. So thank you for using that term. I really like that, Denise.
Oh, thank you. Well, thank you for explaining how that works. It's got to make patients feel comfortable about what they're receiving, you know. And Dr. Fong, is it the same approach with early stage lung cancer?
So early stage lung cancer is kind of treated very differently because it's when we talk about early stage, we really mean just a tumor in the lung and not spread anywhere else. So as a surgeon, I sort of have two roles in taking care of that. Is that one is helping make sure that the diagnosis is correct and that it really is just in that one place and not spread somewhere else in the body where they need Dr. Salgia's expertise to help treat the whole person. And so we do that with our diagnostics, with how we're going to get biopsies and check the lymph nodes and things like that to look for any signs of spread, and also to get enough tissue to make sure that if there is any evidence of spread, that Dr. Salgia can do all of those tests he needs to find out exactly what medications or treatments the patient might need for their specific mutations. And then once we have that, if it does look like the tumor is just one location, then we usually treat it with a local therapy with either radiation or with surgery. And with surgery, you take out the piece of lung that the tumor is in. So to take out the whole piece of lung and to take, not just the tumor itself, but some lung past that so that you have a clean margin for it and some of the lymph nodes around it. I think City of Hope is a fabulous place. In our thoracic department, we do a lot of minimally invasive lung surgery, which I think really benefits our patients. So traditionally, lung surgery was done through a thoracotomy, which is a really big incision in between your rib space that was, kind of about this big and spread your ribs and was quite painful for patients and morbid. But now we do most of our lung resections actually through minimally invasive surgery or robotic surgery through much smaller incisions, like 5 incisions about this big instead. And I think that really benefits the patients in terms of their recovery.
So definitely, if you can get this early, it's a lot better. The treatment seems to be a lot.
So if it ends up being stage 1 lung cancer, generally the treatment is just the local therapy, the surgery or the radiation, and then we monitor at that point. It's only with higher stage tumors or very aggressive appearing tumors that you would need any kind of systemic therapy for early stage cancer.
All right, more incentive definitely to get in there and be part of the clinical trials for screening and get screening and talk to your doctor. I might note you're talking about surgeries. City of Hope performs one of the largest volumes of thoracic surgeries in California. And that's amazing that you have that breadth of expertise from minimally invasive, lung sparing, robotic, laparoscopic. I mean, not every institution has that, right?
No, it's definitely a special thing here at City of Hope, and something that we're really glad to be able to provide for patients.
Okay. All right, moving on to what does it mean when doctors talk about a lung cancer prognosis? When I'm sitting there and you tell me, okay, you have this stage and this is your prognosis. Dr. Salgia, maybe if you could talk about that.
I've been in practice for over 35 years now as an oncologist. And when I was much younger, I would give out all the statistics. But then I learned one thing about statistics. A good statistician can make a pretzel into a straight line. And so we know indeed that prognosis is individually dependent, but prognosis is also dependent on the context of how you respond to therapy. There are generalizations. If you go to Dr. Google as an example and you look at prognosis for stage 1 disease versus stage 4 disease, and then you get all these curves, and those are really generalizations. So please, please, please don't do that because they are clearly generalization. They're population-based statistics. What we have to do is come back to what you said was the personalized medicine and the personalized approach, where we want to make a difference for each one's prognosis. Prognosis depends on a lot of things. How will you be diagnosed? What was the rate limiting step for diagnosis? Did it take a whole year to figure this out, or did you get diagnosed immediately? Then did you start therapy as soon as possible? How were you being monitored? What was the surveillance? And if you had a genetic alteration or these genomic alterations like EGFR or ALK, the prognosis is so much better compared to, let's say, small cell lung cancer as an example. But even small cell lung cancer, we're making a huge difference as well. So yes, we should talk about prognosis, but I think take it with a grain of salt. When patients come to visit me on their first visit, I actually specifically say I don't talk about prognosis because it's really dependent on how they respond to therapy, what happens on an individual basis. And I think we can talk about prognosis over time. We're no Marcus Welby's. Maybe I'm old enough to say that, or we're no House would be the other one, I would say, where they sit down and talk to their patients. We see it on television shows all the time where they say, well, your prognosis such and such. I would get away from that physician if I were you. I would actually say go to a physician who strongly believes that they can impact on the prognosis by changing it.
That it really speaks volumes to cancer patients who are, you're right, go to Dr. Google and say, oh my gosh, looks like I only have 3 years left to live. And these numbers, they're constantly changing, aren't they, with every new treatment that comes out?
Isn't that fantastic? I mean, in my lifetime already, we've seen these numbers changed for the much better. When I was growing up in the system for medical oncology, breast cancer was our ideal, seeing even for stage 4 patients, breast cancer patients surviving, many of them for a long time, and it was considered, quote unquote, as a chronic disease. And since I had started my career in lung cancer, we didn't used to see that as a comparable to breast cancer. But now I think in a subset of population for lung cancer patients, we're there, but in other subset of population, we're not there. So I think what we have to do is keep changing the curve for the better of our patients. But I also warn us, make sure that there's no toxicity or minimizing the toxicity. That's an important issue for us in our field.
Yes, absolutely. I mean, we're going to talk about that, but I want to remind everybody right now who are listening, if you have any questions, because we've brought up a lot of topics here, any questions about lung cancer, please put it in the Q&A, and we're going to get to that right after we ask just a few more questions here about prevention. Because from what I learned from the American Cancer Society is that 40% of cancers have a modifiable risk factor, which is exciting because that's like nearly half of cancers out there. You can change your trajectory for getting that. So there is a lot of control and power that we have as individuals. So Dr. Fong and Dr. Salgia, feel free to jump in there. Let's talk about ways that we can lower our chances of getting lung cancer. Whoever wants to start.
Sure. The biggest modifiable risk factor.
Oh,
Fong, it's hard.
are you?
Sorry, I'm not muted, but I guess it's not picking me up right away. Can you
We hear you, yes.
Okay, wonderful. The most modifiable risk factor we have in lung cancer, as we've mentioned, and I'm sure most of our patients know, is smoking. That it is still, an incredibly prevalent thing in our cancer populations, and that it not only helps with reducing your risk of lung cancer, it helps with your lung health, it helps with your heart health, it helps with your, the health of your fingers and your toes and your blood vessels. So overall, I think the biggest thing we could tell patients is if you're smoking, stop smoking. That's the best way you can try and prevent lung cancer.
Yeah,
Okay, what
thank
if
you. Oh,
what
thank you,
if you
Dr.
have
Fong.
a secondhand smoke? I mean, what if you have somebody in your house who smokes? What can you do?
Maybe yell at them, and not to do it, and really encourage them. I mean, you want to do it with love, of course. Um, it's very important. Secondhand smoking, just like Dr. Fong said, it's just as bad as smoking. Vaping is just as bad too. And also preventing all this pollution to enter into your airways. You won't see that if you'll see the effects in terms of, let's say, breathing issues and so forth, but 20, 30 years down the line, we might see more lung cancer. So can you have air purifiers inside your home? Can you also change your diet to make sure it's not all bad diet in its own right? Mind, body, and spirit and soul is clearly incredibly important. What our ancestors did, right? In terms of um, thinking about the mind body is truly very important, and we should be able to do that as well. But try to stay away. I love what Dr. Fong said. Try to stay away from all these toxins.
What about, since we're talking about smoking, third hand smoke? I mean, in the furniture and the curtains, how dangerous is that?
Dr. Fong?
Um, so you mean like the smoke that someone else has already smoked in the area and it's sort of gotten into all of the things?
Yeah.
I think it's definitely not as dangerous as, directly inhaling from a cigarette into your lungs, but if you can smell it, there's something in the air coming from it. So, I mean, it is not without risks, but so I think anytime you can minimize those toxins coming into your body, it's going to be better for your lungs.
And Dr. Fong, we've mentioned radon, air pollution, avoiding exposure to carcinogens. You have any advice for doing that?
Um, uh, I think Dr. Salgia made a good point, having air filters in your house, changing the air filters in your house or your car when they're supposed to be changed. I know that's one of those things that's, by the time you remember it, it's probably been longer than it should have been. I know it is for me at home. But maybe setting a reminder so that you actually do that regularly when you're supposed to try and protect your air quality inside your home. And then try and reduce other things, turn the fan on when you're cooking if you have on the stove, or open a window can help reduce fumes in your house. And uh, obviously avoiding noxious chemicals in a closed space or anything like that too.
Yeah. Yeah, absolutely. I mean, we're very, very aware of that given the fires and radon. Like, how do you check for radon and who is more at risk of having radon in their house?
So when I was in New England, in Boston, New Hampshire is a granite state, and there was a lot of radon. And those who actually had basements, the radon accumulates. So I remember when we were trying to sell our house over in Boston, we checked for radon, and usually I think the levels are up to 2 picocuries per liter, but ours was like 4, which is slightly high. But certain basements had levels of 100 or 1,000. And then you can mitigate that by just putting in a simple pump. And that's what we did, and it resolved right away. So you still should be checking radon. There are radon kits as well. And I think there are sites on American Lung Association and other associations where you can actually see how to check for radon. And I do think one should check for radon nationwide. So when we moved from Boston to Chicago, we still insisted that radon should be checked. I think radon should be checked in California as well. And these are dangerous things if you get exposed to them for a long time. The miners in Utah, for example, get exposed to radon all the time, right? Uranium miners. But then the troublesome part is that those miners not only get exposed to radon, but they also smoke. So I wonder, theoretically, if we get exposed to radon and we get all this pollution, is that a synergism for developing lung cancer? Don't know. I think we have to follow these statistics over time. But the more you can mitigate those circumstances, the better it is.
Okay. And we touched on screening. People who are listening out there, who are the ones who need to get in and talk to their doctor about screening?
Dr. Fong?
Usually we think of people with heavy smoking histories are 100% should be screened. People with more than 30 pack smoke year histories who have been quit smoking less than 15 years ago is, I think, the technical guidelines. But personally, I feel like if you smoked a lot when you were now or younger, or if you had a lot of exposure into family members or a job that had a lot of exposures, it's definitely worth something to be keeping in mind with your primary care doctor.
Okay.
And we have a program, Denise, to Dr. Fong's colleague, Dr. Raz, and our colleague, Dr. Sandoval and Dr. Gray are really leading some studies for screening, even for those who are non-smokers, and they might have a potential for developing lung cancer. So get involved with those clinical trials. We're big believers, Dr. Fong, myself, all of us in our thoracic program, in trying to see if patients and subjects would qualify for clinical trials. And I think that's really important for us to make a difference for the future.
Yeah, and I know you are a big believer in clinical trials because from what I understand, City of Hope is conducting about 800 clinical trials right now, which is the most in California. So there definitely is hope there because many of those drugs, I mean, some of them could be on the cusp of FDA approval. And so getting into a trial or even the screening, these are ways for you to get the best treatment up front before anyone else. So, Dr. Salgia, how do you get into a clinical trial? Is this something you just talk to your doctor? Is there a way for you to find out about it by yourself?
So multiple ways. Yes, you can find out about it by yourself and going to the NCI.gov website, for example, or the American Cancer Society website, and you can look into those clinical trials. You should also talk to your doctor or your nurse practitioner or PA, so your healthcare provider to say, are there any clinical trials that you know of? At the same time, they can reach out to any one of us to say, are there potential trials? They can look on our websites as well to say, are there potential clinical trials? So there are many ways of looking into that. But just don't stop by saying, somebody else is going to look at it for me, but be proactive to be able to be engaged in seeing, are there potential trials? And some institutions might have it, some institution may not. What I love about Southern California as an example, and I'll give you the example for medical oncologists, we all work very closely together. So as an example, if my colleague sees a patient at UCLA and they don't have a clinical trial, we have each other's cell phone numbers. So they just text me or text my partners and say, hey, do you have a clinical trial for a person like this, blah, blah, blah. And then we look into that. And we have to just make sure we're HIPAA compliant, of course, always. And then we cross communicate. Then we also have a whole national network, right? We have clinical trials in Chicago, Atlanta, Phoenix, that City of Hope is actually in those cities themselves as well, or in those areas. So we can provide those types of clinical trials across the nation. But then we work together with other institutions, be it MD Anderson or Memorial Sloan Kettering or the Dana-Farber or University of Chicago. We're all pretty good. I like us as medical oncologists and as thoracic oncologists and surgical oncologists. We actually love taking care of our patients and also providing that whatever the patients need and the trials, if we don't have it, somebody else might have it, and we encourage that, and vice versa.
Yeah, okay. A lot of information and a lot of resources where people can go to find out about this. Thank you. Let's talk a little bit about the wildfires. Because that was pretty bad. And I actually was at City of Hope this week, and they were telling me there that you guys were on the verge of evacuating. I mean, I can't even imagine trying to get all your patients out of your hospital, many of them critically ill, trying to get to other hospitals. But luckily, fortunately, that didn't have to happen. But what we saw in January and what we've seen before that, and we will continue to see, it's just really volatile organic compounds are what doctors are talking about, asbestos, lead. That was in the air, and there were strong concentrations of it for a few days. What is it okay to keep living in LA? And when these things come around, what can we do to protect ourselves? Want to start, Dr. Fong?
Sure. I think the first place I usually start is by looking at the air quality indicators. There's a bunch of different apps and things you can look at to try and figure out what the air looks like in your area. Obviously, that's impacted by a lot of things, right? If it rained yesterday, that cleans a lot of stuff out of the air. And if the wind is blowing, there were days where right around the fires, the wind was blowing right towards City of Hope Hospital. And so then everything was sort of under a dark cloud, whereas the wind shifted and then it blew all away. And then the air was much cleaner and better quality. And so just checking those air quality indicators in your area can help give you a starting point for how safe it is to be outside doing, strenuous things and just in general spending time outside.
So you're not going to move, right? We
No,
take
I'm not. I am gonna, if it looks a little hazy out, I still check just to make sure. I mean, even just living in Los Angeles, sometimes it's good to just check and make sure the air is a good quality outside before you go for a run or a hike or anything.
Yeah, we have to look at that the way we look at our weather apps as well, you
Mhm.
know.
I think it
Uh,
actually comes on the Apple Weather app now in the area, so that's even just an easy place to start.
yeah, okay, good. Dr. Salgia, are you going to continue to live in LA? What precautions are you going to take?
I always say I moved from Chicago and I live in paradise. And I don't mean the TV show Hulu that has, but at the end of the day, we survived the Eaton fire. We were one of the first ones affected. I live by Eaton Canyon, and so coming back to City of Hope first and foremost, yeah, we were quite concerned, right? January 7th, of course, Palisades fires initially, and then the Eaton fire started around 6:30 at night on January 7th, that Tuesday. And then we knew those winds were like 90 to 100 miles an hour, and we live right here in Eaton Canyon. And so then we evacuated in about 7 minutes, and then had to also get to the hospital too to make sure our patients were okay. And thankfully, what happened around 4 to 5 a.m. that morning of January 8th, the wind shifted from northeast to going northwest because we saw that coming at the hospital towards us, and Duarte especially. But then thankfully it shifted, but we were prepared to evacuate the command center. We take pride in all of the people who came to the hospital, our physicians, our nurses, MAs, all the healthcare providers, all the staff, all the administration, working with LA County. And I'm so thankful, and we're also thankful for everyone in LA, the firefighters, the immediate people who acted on these. And at the end of the day, we learned a lot. And what we learned was the human kindness, the kindness of others, the getting together of everyone to make sure that everyone was safe. We truly realized that so many people lost their houses. And, just yesterday, we ended up going to FEMA as an example. Yesterday, my wife and I, and just going through Altadena and Pasadena as an example, it's devastating. It's surreal, right? And all of those that you face and all the asbestos, the lithium batteries, the cars melted away, are very important for us to acknowledge and recognize that so many lives have been affected. But what I love about LA and what I love about Southern California, we're in it together. I like those signs in Altadena, especially Altadena is not for sale. I love it. And we are here, we're strong together. I agree completely with Dr. Fong, but just be careful. Wear an N95 mask outside now because these are dangerous areas to traverse in. But over time, we will recuperate. We will really rebuild ourselves. And at the end of the day, what Dr. Fong, myself, all of us worry about at the City of Hope and all the healthcare providers, we want to prevent lung disease. We want to prevent lung cancer. American Lung Cancer Society, American Lung Cancer Association, American Cancer Society, others, the Go-To Foundation, everyone is so devoted to making sure our lives are going to be okay. So yeah, we're not moving. This is paradise, and we're going to continue staying here.
I needed that dose of optimism. Thank you so much. Yeah, because I think we're all still getting over that. And yeah, hope is for our body, mind, and spirit, not just our bodies, and not just our lungs, not just physical. So thank you. Why don't we get to some of these audience questions now? We have Allison from Irvine, and she's asking, if someone you love is diagnosed, what are the first three things a family should do because you get so overwhelmed?
Dr. Fong?
Um, that is a very complicated question. I think it's wonderful for families to be thinking about how to do best support somebody. Usually in the first couple weeks after diagnosis, there's a lot of changes and shifting plans. You have to see a whole bunch of different doctors. You have to get a ton of different tests. You're probably very anxious about what does all of this mean for my health, my life, what comes next. And I think trying to support somebody through that, helping them stay organized, helping them get places if they feel yucky and need help driving or help getting the rest of their life organized, helping them set up things and follow up on things. I think in general, right after diagnosis is a little bit of a time of chaos, and helping to try and make your family member's life as supported and straightforward and as possible, I think is probably a good starting point.
I mean, it is such a blow to have that prognosis and just knowing that what's for taking that first step. So thank you for that. We have a question. Dr. Salgia, you talked about all those different drugs that we hear ads about. And so someone in the audience is asking, there are many ads and articles about new discovered drugs that increases life for those who have cancer. Are they believable?
Yeah, so I see a lot of these TV commercials, you should get this drug or you should get this drug and you should talk to your doctor. And then at the end, they talk very fast and you can get nausea, vomiting, diarrhea, stupor, coma, death, right? So just be careful. What you see being advertised, what you see on Dr. Google may or may not be correct for your disease. And I think you should talk to your healthcare providers to make sure that these are indeed the right drugs. Number of patients, for example, have, and I see in the chat, for example, somebody with a KRAS mutation. So we've had patients who've had, for example, a KRAS mutation, and they say, hey, I would like to get this drug called osimertinib. It's the wrong drug. Osimertinib or Tagrisso is for EGFR. It's not for KRAS. But if you were to say adagrasib or sotorasib, that's the right drug for KRAS mutation, but only for G12C. But if you have a G12D or a G12V or a KRAS amplification, those drugs don't work. So are they believable or not? I think to a certain extent, in a generalistic way, maybe, but I think you need to dig deeper to ask your healthcare providers for advice.
So you started to also answer Holly's question from Ventura about KRAS. She's also asking, are there any clinical trials for that?
Yeah, we do a lot of research at City of Hope and KRAS and other mutations in lung cancer. We do a lot of that, or even non-mutated lung cancer. And yeah, there are lots of clinical trials, and it depends on which KRAS. I alluded to that. Is it in codon 12 or codon 13 or codon 61? I'm trying to confuse everyone because that's the intense discussions that we have in our own minds sometimes too, right? And if it's codon 12, is it a G12C, G12D, G12V? Those are the most common for lung cancer. But is it a codon 13 or is it a codon 61? So yes, there are clinical trials. There are specific small molecule inhibitors or degraders or even potentially vaccine trials. And those are all potential considerations.
I want to take this opportunity to remind people that if you have any questions, because we have some amazing experts, as you can tell here, this is the opportunity for you to ask. Please put your question in the Q&A, and we'll go ahead and ask those. Earlier, you talked a lot about late-stage cancers, Dr. Salgia. Can you talk a little bit briefly? There's someone who's joining who wants to know about what the treatments are for late stage.
So late stage, again, depends on the type of tumor, first and foremost, and depends on if you have where the tumor is. Suppose it's a large lesion in the brain and you got a lot of swelling. Sometimes you need to resect that out, or sometimes you need radiation therapy. But suppose if it's late stage tumor and you need medical oncology as a therapeutic, then we decide really for non-small cell lung cancer, for example, for adenocarcinoma, which is the most common, what are the genetic genomic alterations? Then if it's, let's say, an EGFR that I talked about earlier versus ALK versus ROS1 or MET and so forth, then depending on what genomic alteration you have, or even immunotherapy, then we consider what are the options. So let's go through, for example, an EGFR patient. So if somebody has an EGFR mutation, we really look at, is it an EGFR mutation exon 19 deletion? Is it a 746 versus a 747? Is it an exon 21 alteration, an L858R? Is it an exon 20 insertion deletion? Is it an exon 18 alteration? If it's an exon 20 alteration, we know a majority of time agents such as osimertinib won't work, but amivantamab is going to work. But if it's an exon 19 or an exon 21, then osimertinib might work, or lazertinib amivantamab might work. So we really systematically go through this. And you can imagine this, Denise, is that we get 20 minutes for a follow-up with the patient. You can't decide all that in 20 minutes. So you have to do your homework. We have what's called a tumor board where we talk about our patients to say, how do we come up with a consensus? We have team huddles to be able to go through each patient every week to be able to say, what is the best therapy? I'll text Dr. Fong, or Dr. Fong will text me saying, hey, I'm seeing a patient this and this. What would you consider? And amazingly enough, City of Hope has started this one process just yesterday. I was leading the faculty meeting for medical oncology, where we're going to get what is called a curbside evaluation. You run into your colleagues, let's say you're on the same floor and you have this similar offices, so you're next to each other, and you say, hey, Dr. Jones, what do you think about this person, and blah, blah, blah. So we're starting this actually nationwide within City of Hope to be able to cross-communicate with every physician to say, I got a very interesting question for you. What do you think about this? So all these therapies are important, but what's also important to be in a group where you can cross-communicate and cross-talk, so you have a multidisciplinary effort. I think you're
Curbside
on.
care, that's innovative.
Yeah.
I like that term. This is
We
a
don't
very
charge for that either, by the way, Denise.
wonderful. Here's a practical question about air purifiers, because we mentioned it. We talk about air purifiers. What should you look for? Mark from Whittier wants to know, what should you look for in a good air purifier? And I've heard like MERV ratings.
Dr. Fong?
Oh, I'm sorry. I am not an expert in air purifiers. I know my husband does a lot of research online and figures out what, usually I think he picks the wire cutter's favorite air purifier. And but I defer to you, Dr. Salgia, if you know a little bit more about that than I do.
Thank you, Dr. Fong. I'm in your boat now. All we did when we had the Eaton fire, we were evacuated for 3 weeks. Then we had to come back into the house, thankfully, and we're blessed in the sense that our house is standing. We had to buy air purifiers. Costco was where we end up going to. I'm not trying to sell Costco, don't get me wrong, but we found them, and then we just bought them. But we're not the experts. I
Uh,
think we have to get
I
the
love like you're like all of us when it comes to that. So we did a few stories here following the fires, and like some of the air quality experts are look for an air purifier that has a MERV rating of at least 13. So I think they could range from, 1 all the way to 20 something. So if it's at least 13, that's good. I guess if you want to pay more for a higher MERV rating, then that'll make you feel better. That's good. It's like sunscreen, I imagine. So at least a rating of 13. Doug from Duarte, since we're talking about wildfires, for those of us who live in these areas, especially those with greater exposure, such as people who are in the emergency cleanup crews, would you recommend getting a low dose CT scanning, low dose CT screening for those people?
Dr. Fong.
I think my first recommendation would be to wear a mask if you're actually in the areas where you're going to be exposed to a lot of um, toxins, because prevention is going to be the most important thing, is to try and prevent your lungs from being exposed to those toxins while you're cleaning up. And we all, through COVID and recent years, have had experience wearing masks. It's very doable. Get an N95 and it will keep if it can keep a virus out, it can keep small particles out as you're cleaning it up. And so I think that or a respirator or whatever the recommendations are for the kinds of things that you're cleaning up. But I think prevention is going to be the most important part. I think a low dose CT is unlikely to show anything but irritation in your lungs in the near term right after an exposure like that. But what we really worry about is years from now, once that has had time to sort of sit and percolate what it might mean for your lungs.
And it's very important, just to add on to Dr. Fong too, is we have to follow guidelines, but guidelines will change over time. And so talk to your healthcare providers to see if that's needed or not. As an example, I know there are some programs like in the state of New York where they're screening firefighters constantly to be able to say, Will they develop lung cancer sooner than others? Will they develop lung disease than others? And clearly, clinical trials, getting involved with those types of programs is important. And at the same time, a number of us are thinking a lot about how do we do these screenings. So we actually have a screening program here at City of Hope as well. You can definitely talk to our screening program leaders as well. And at the same time, is it appropriate or not? We're not quite sure. I love the prevention idea, but let's also continue to follow our colleagues, our patients, the population to make a difference, but we're not quite sure what the recommendations for today are, but I think that's going to change tomorrow.
All right. We're talking about the lungs here, but also the whole person, the whole patient when they come in seeking your help. Ben from Venice wants to know what your opinion is on holistic therapies, because I know a lot of people want to do massage or meditation, that kind of thing while they're undergoing treatment. Can they help with recovery?
Yeah. So I'll talk about that because we just got a $100 million endowment to study integrative medicine at City of Hope. That's being led by Dr. Lee here at City of Hope. And he's really developed a fantastic program of integrative medicine. Should you think about acupuncture, massage therapy, music therapy, at the same time, what other quote unquote alternative therapy should one think about? People think a lot about CBD, THC, Ayurvedic medicine, right? Turmeric, as well as amla or other things. I don't think you should take them unless you talk to your healthcare providers. You should also potentially get a consultation with an integrative medicine expert. What I like about Southern California compared to the Midwest or the East Coast, very much many people are in tune with the holistic care, which is what we love as well. But work in coordination, that is your integrative medicine provider with the other providers to be able to come up with the right equation. So one counterexample I'll give, I love massage or acupuncture and so forth. But we found out as an example that patients who take CBD/THC and get immunotherapy, the immunotherapy doesn't work as well. So you want to be careful. You want to be careful because if you're taking something and you don't tell your provider that you're taking this and that immunotherapy doesn't work, then you can't figure out, was it because the cancer was truly resistant or did you make it resistant?
Important points. Really quickly, we have this one question. Cancer patients suffer unbearable pain and are given some medication to alleviate pain. Are there any drugs that eliminate pain that when it becomes unbearable?
Yeah, so for sure, I'd love Dr. Fong's opinion as well. The answer is yes. We have a huge supportive care service here and pain management service, and they can be seen for that reason. Dr. Fong?
Sure. I think just like Dr. Salgia said, we try and take sort of a multidisciplinary approach, and we get our supportive care medicine doctors who specialize in helping patients symptoms. Their whole job is to help manage unbearable symptoms like what you're talking about. And sometimes that is, stronger pain meds like narcotics, but sometimes it's not. Sometimes it's acupuncture. Sometimes it's making sure that, the bowels are moving properly so that's not adding to patients' discomfort. Sometimes it's helping figure out the right regimen of non-narcotic pain medicines so that the patient can be comfortable and enjoy their quality of life. And sometimes it's, even something as simple as like getting an injection, a numbing injection to help with a specific location that's causing them a lot of pain. So it's wonderful to have those colleagues here that can sort of help synthesize that and come up with an individualized plan to help a patient with their symptoms.
Okay. With that, we're going to have to wrap up here. I just want to let everyone know if you had a question, the team's going to do their best to email those answers to you. I want to thank Dr. Salgia and Dr. Fong of City of Hope for enlightening us with this conversation. I want to thank the American Lung Association for all the work they do to fight for lung health for all. And most of all, I just want to thank all of you for attending. This recording will be available shortly, and we invite you to share it with anyone in your community who has questions about lung cancer. We hope you take the information that you heard today and you apply it to your lives, to the lives of your loved ones, and that you stay healthy. Thanks again.
Thank you.
Thank you. Bye, everyone. Thank you, Denise. Thank you, Dr. Fong.
Thank you.
Bye.
Bye-bye.
Thank you, everyone. Bye, everyone.
Thank you.